Hi, good afternoon, ladies and gentlemen. My name's Dr. Arthur Loussararian. I'm a cardiologist at Mission Heritage Medical Group, and I'm going to talk to you today about heart disease. And the title is, Do I Have Heart Disease? Just a little bit about my background. I graduated from the UCLA School of Medicine. I've been in private practice for the last 23 years with Mission Heritage Medical Group. I'm the director of clinical research at Mission Cardiovascular Institute. My specialty is interventional cardiology and vascular disease. And my practice philosophy is I enjoy partnering with my patients to help them achieve a healthy and productive lifestyle. So we're going to talk about heart disease. And a lot of patients come to see me in the office, and many of them want to know, do I have heart disease? Am I at risk for a heart attack? Sometimes I get chest pains. Do I have a heart problem? My father or my mother had heart disease. Will I get it too? My work colleague who's about my age just had a coronary stent. Should I get checked out? These are the real world questions that my patients ask me. And what they are really asking me is, doctor, can you tell me what is in my future? Do you have a crystal ball? And so the question is, can we foretell the future when it comes to heart disease? Can we predict heart attacks? I'm going to show you some evidence that shows that we can. So I'm going to talk about three crises. One of them is medical or cardiology related. The other two are not. But I'm going to draw parallels and analogies among those three, kind of in a fun way, to understand really the science of predicting heart attack versus the science of predicting other things that affect us. So crisis one, this is a patient I had not too long ago, 40-year-old man who developed chest pain while surfing, drove himself home, and then had a cardiac arrest. The paramedics were called. Upon their arrival, he did not have a pulse or blood pressure and had to be shocked twice. In the emergency room at Mission, he was shocked another time and placed on a ventilator. An EKG showed that he was having a heart attack. At that time, I was called because I was the doctor on call. And after looking at him and looking at his EKG, I took him to the cath lab. He underwent emergency angioplasty and placement of a cardiac assist device for cardiogenic shock. He was in the intensive care unit on a ventilator for 5 days, but he survived and he improved. And after a 10-day hospitalization, he went home. History was later obtained that he had high cholesterol and that he had been having intermittent symptoms of chest pain for several months, and that his father had a history of heart attack. And so knowing this information in the light of what we're going to discuss, could this heart attack have been foreseen and could it have been prevented? Which is a very key and important question. How good are we at predicting heart attacks? This is the second crisis that I'll talk about. It's not medically related, but for purpose of discussion, let's delve into it a little bit. Crisis 2, the Northridge earthquake, 1994, scale 6.7, 72 people died, $20 billion in damages, $49 billion in economic loss. And at that time, it was the costliest US disaster in history. How good are we at predicting earthquakes? Could we have predicted that or prevented it? Well, we know sort of why earthquakes happen. There are these things called tectonic plates. They're huge masses of land, and they shift along predictable lines. These are fault lines. And so we know where earthquakes happen, but unfortunately, that's kind of all we know. We don't know when they're going to happen. And if we did, we could do something to maybe not be in that area. This is a little more close up here, California fault lines. These are where the fault lines are in California. We know the earthquakes happen here usually, and they happen every 100 to 200 years. But that's a pretty wide period of time, and so really doesn't help us much in knowing what's going to happen next week or after next week. So as far as crystal balls, when it comes to earthquakes, we don't really have too many. We have, geological crystal ball telling us over geologic time periods where earthquakes will happen. And we have the Richter scale, which tells us an earthquake's happening right now, but you don't really need a machine to tell you that if you're in an earthquake. So earthquake science isn't so good. Hopefully heart science is better, but let's just keep going. How good are we at predicting earthquakes? Not very good. Let's look at another crisis. Crisis 3, Hurricane Katrina, 2005, 1,800 people died, $161 billion in damages. New Orleans still hasn't recovered. How good is hurricane prediction? These are all the crystal balls. Are any of them known to us? Well, yeah, lots of them are. We know from yearly rainfall measurements where the rain falls hardest every year. So we know where these hurricanes happen. Beyond that, we know what months they happen in. We know that this is hurricane season right now, September. We just had one, Hurricane Ida, which fortunately didn't hit land in Louisiana or the southern states, but we know the months they happen. We also have satellite, and we know days before they happen, up to a week before they happen. We can see the hurricane forming, and we can see which direction it's moving, how quickly it's moving, where it's headed, so that people have time to evacuate. This is tremendously valuable knowledge. If we knew this in the heart attack setting, this would really help us. Then we go down to the bottom left corner here. Without any fancy machinery, you can look out your window and know 6 hours before that hurricane's coming. Well, that kind of helps you, but not as much as if you had the satellite, which tells you days before. And then, of course, on the bottom right, 20 minutes before the hurricane hits, it's pretty obvious to everybody that it's about to hit. And looking again at Hurricane Katrina, this spans out 3-4 days ahead of time where it was heading, how fast it was moving, how fast the wind speed was. And the rest of us who were watching this across the country were saying, wow, it's going to hit land. Why don't those people get out of there? And so that raises the question, having information is great, but it's not the end of the story. You have to do something useful with that information. You have to act on that information. And in fact, out of 1.7 million people who lived in New Orleans area, about 1.5 million evacuated, but about 150,000 to 200,000 did not. And you saw them on television. Now, some of them, they didn't have access to an automobile, et cetera. There are all kinds of social factors, but the point is that there were some people who could have changed their behavior but didn't, and that's a whole separate issue. So how good are we at predicting hurricanes? We're pretty good. So then coming back around to our topic of interest, are heart attacks more like earthquakes or hurricanes? Can we predict? Can we prevent? And that is an interesting question. So more specific questions we can ask are, what is my risk for a heart attack in my lifetime, in the next decade, in the next few years, in the next few weeks or months, or in the next few minutes? So here are all the crystal balls for heart disease. Well, everyone knows what an EKG is. EKG measures the electrical activity of your heart, and it can tell you if you're having a heart attack right now. Now, that's sort of useful information, not so much for prevention, but it does help the doctor figure out how to treat you, but it doesn't help you that much in terms of dodging a bullet. Fortunately, we have a lot more knowledge about heart disease. We know the risk factors that determine lifetime risk for heart attack. We know the factors that set someone up to be more likely to have a cardiac event or a heart attack. And these you can look at on a level of molecules, but they translate to lifestyle behaviors as well as genetics. The molecules involved in making a cholesterol plaque form in your heart are closely tied to your diet, your social habits, and your genes. So this is a diagram of your artery, and these cells over here are the lining of your artery. This is your blood stream here. And what happens here is that cholesterol particles can damage the lining of your artery and gain entry underneath the lining of your artery and start depositing underneath this lining and becoming a cholesterol plaque in your artery. And the factors that propagate this or make it more likely to happen involve all these things that I've put here in the periphery, such as tobacco smoking. Tobacco smoking injures the lining of your arteries and makes it easier for cholesterol particles to enter into your artery wall. Diabetes mellitus, same type of thing. Diabetics are more prone to getting damaged endothelium and cholesterol plaque developing in the walls of the artery. Hypertension, high LDL cholesterol, low HDL cholesterol. And then we have here a lot of genetic things on the right side: age, family history, and male gender, which we can't really control, but these also tie into the likelihood of cholesterol plaque deposition and growth in your artery wall. And so we know statistically, by knowing your risk factors, we know statistically your lifetime risk for getting heart disease and having a heart attack. But that's over a span of 50 to 80 years. Can we do better than that? The answer is yes, we can. If your doctor scans you with a CAT scan and sees calcium in your coronary arteries, these are your coronary arteries here, then he or she knows that you have already the beginnings of plaque deposition in your artery, which puts you at a higher risk for future heart attack. This is it's a cartoon of your artery wall. And on the left side is the healthy artery wall. And as time progresses, going from left to right, you get the deposition of the fatty plaque in the artery. And where the fat and cholesterol deposit, eventually calcium also deposits. And keep that in mind for the later discussion that's going to follow. But as the plaque grows and matures, there comes a point where the plaque can become unstable and break open and expose its contents into the blood. And when this happens, the blood will clot. A clot will form and will plug the artery. And that is what a heart attack is. That essentially is what causes heart attack. If that clot gets broken up by the body's own mechanisms, then someone's heart attack will be aborted and they'll probably survive. If that clot can't be broken up by the body's mechanisms, then the heart attack will complete itself. And if this person doesn't get to a hospital and have an angioplasty to open up that blockage, they're going to have a sizable heart attack. This is a CAT scanner. And with a CAT scanner, you can see the calcium. X-rays can see calcium. They can't see plaque. but calcium is a marker for plaque. So wherever wherever plaque deposits, calcium will soon follow, and we can measure it. We can see where it is. We can see how much there is, and we can gain an assessment of the burden of plaque that you have in your coronary arteries, and that translates to future risk of heart attack. This slide shows you something called calcium score and coronary risk. The CAT scan can measure calcium score, and the higher your calcium score, the more plaque you have, and the higher your risk of heart attack. Here you see in blue someone with a calcium score of 300 and their risk of events over time. This is over 5 years. And you can see that with passing time, there's people have more events with a calcium score of greater than 300. If your calcium score is 100 to 300, then you still have events, but on a lower rate than someone who has a higher calcium score. Going lower still, if your calcium score is 1 to 100, you have coronary events, but at a lower rate and a slower rate than people with higher calcium score. Finally, if your calcium score is 0, you have very few cardiac events. So in summary, having a low calcium score means you have little or no plaque, and your event rate for heart attacks low. The higher your calcium score is, the greater your annual risk is of heart attack. So this is kind of a risk predictor. Knowing your calcium score tells you what's coming in the coming years or decades. Another predictor or marker is using ultrasound. Many of you have had a carotid ultrasound or other kinds of ultrasound, and any ultrasound that looks at any vascular structure, such as in your legs or in your carotid artery, can tell you if you have plaque. You can see the plaque here on an ultrasound. And if you see that, we know that plaque doesn't just occur in one place, it's universal. So if you have plaque in your carotid, you probably have it in your heart as well. And so that means you're at risk for heart attack. So this is a marker in someone who has no symptoms. It's a marker of things brewing in your arterial circulation that could increase your risk of heart attack. So when we measure your ultrasound in your legs, we calculate something called an ankle brachial index. And you can have a normal ankle brachial index, or you can have one that's too high or too low. If it's too high or too low, both of those are abnormal. And if you plot the ankle brachial index lines and you look over time and you assess the accumulation of events, you see that someone with a normal ankle brachial index has a certain event rate, but someone with a high or too high or too low ankle brachial index has a greater rate of cardiac events than someone with a normal ankle brachial index. So the ankle brachial index is a marker of plaque in your legs, and the more you have, the higher your event rate. So this is another predictor of future cardiac events. The third modality that we have that we can measure, this is similar to the coronary calcium scan, but it actually takes it a step further. It's a coronary CT angiogram. It's a non-invasive type of an angiogram where you just need an IV and some dye is injected, and you get a CAT scan that looks at your coronary arteries, and you can actually see the coronary arteries, and you can see if there's any blockages in them. Here you see the left anterior descending artery. And so by seeing where the blockages are, how many there are, we can determine how much greater your risk is for heart attack. Here is plotting something called CTA risk score by looking at the CT angiogram versus time versus cardiac events. And you can see that the higher your risk score, the lower your event-free survival. So if you have a low risk score, you have a greater survival, event-free. And if you have a higher risk score, you have a lower event-free survival. Again, a predictor of cardiac events. So, crystal ball secret. Markers of plaque are markers of coronary risk. The coronary calcium scan is a very strong predictor. The ankle brachial index is a very strong predictor. Coronary CT angiogram is a very strong predictor. And carotid ultrasound is a strong predictor. So can we do better than that? Well, beyond knowing if you have plaque, whether or not you have plaque, we can also go a step further and understand if that plaque is compromising blood flow. Because the CAT scan, the calcium score can tell you how much calcium there is, but it can't really tell you how much of a blockage you have. If you do a physiologic test, like a stress test, that can give you a lot of information. So a stress test works on the principle that the heart needs blood to work. It's just like any other muscle. And when it's at rest, it doesn't need a lot of blood. But when it's placed under stress conditions, it needs to work harder, so it needs more blood supply. Well, the arteries, the coronary arteries supply blood to the heart. And if those coronary arteries are wide open, there's an unlimited number or an unlimited amount of blood they can supply when the heart is needing more. But if the coronary arteries have a fixed blockage and obstruction, then when the heart exercises and needs more blood, there's only a fixed amount of blood that the coronaries can supply. It can't increase, it can't ramp up that supply. And so you have a supply-demand mismatch. And we can detect that by looking at what happens to your EKG when you walk. And so it's a way of measuring whether the plaque in your heart is enough to cause blood flow and a deficiency of blood flow. So this is some data looking at something called the Duke treadmill score, and that's calculated based on how many minutes you walk, whether you have chest pain, and how much change there is on your EKG, and it gives you a score. And if you have a low score, you have a very high rate of survival over the next 4 years. If you have a moderately depressed score, your survival is good, but not as good. And if you have a high Duke treadmill score, your survival is worse. And so the treadmill is yet another tool and predictor that we have. We can add stuff to that treadmill by adding imaging. This is nuclear imaging. And then here you see echo imaging. So this is called a stress nuclear or a stress echo. So it's still a treadmill, you still walk, we still monitor your blood pressure and symptoms and EKG. But after you finish walking, you either do a nuclear camera or you go, we do an echocardiogram, which is an ultrasound, and we can actually see what's happening to the blood flow in the case of nuclear, or what's happening to the muscle contractions in your heart when it comes to echo. And we can localize which area of the heart is not getting enough blood flow by noticing, by tracking where the blood is flowing by nuclear isotope, or by looking which walls are having difficulty contracting by looking at it with echo. So if we see large areas where blood's not flowing or large areas where the muscle's not contracting, we know you have something called ischemia, and we know that it's severe because it's involving a large portion of your heart. And this is a graph of annual rate of death or heart attack plotted against how much ischemia is showing on your nuclear stress test or echo stress test. If you have no ischemia, you have a very low risk of death or heart attack. If you have mild ischemia that involves less than 5% of your heart muscle, you have a little bit increased risk of heart attack and death. If you have moderate ischemia or severe ischemia, particularly if it involves more than 10% of your heart muscle, you have a much higher risk of heart attack and death. So this again is valuable prognostic information. So here we are back on our looking at our crystal balls, and then the next to the last one is symptoms. This is one of the last signs. You know, we talked about the lifetime risk, the decade risk, the monthly risk. One of the later signs is symptoms. So things can be brewing for decades in your heart and be completely silent and only detected by these crystal balls that we've identified. But then in the later stages, when the artery becomes narrowed, you begin developing symptoms. And I'm going to review some of these symptoms here for you. You know most of them because heart disease is pretty well publicized, but the classic symptoms are chest pain, shortness of breath, early fatigue, low stamina, something called silent ischemia. Silent ischemia is when you have ischemia, but you don't really have classic symptoms. And the two groups of people who tend to get silent ischemia are people over 75 or diabetics. And that's because the nerves that innervate the heart are not quite as sensitive. And so you may not feel the symptoms when your heart is lacking blood flow. So to summarize, in your thinking about heart disease and trying to assess your risk for heart disease, there's decade long, or I'm sorry, there's lifespan long risk, and that's assessed by looking at your risk factors like your family history, your history of smoking, hypertension, diabetes, etc. That all translates into your lifetime risk for heart disease. Then there's modalities that can look at your risk over a span of 5 years, 10 years. And these are the markers of plaque that I talked about: the calcium score, the ultrasound, the CT angiogram. Those tell you about your 5 to 10 year risk of heart attack. Then there's stress testing, which can tell you if you have blockages that are narrowing your coronary arteries to the point where blood flow has become compromised. And that alludes more to your risk over the next few months or years. And then lastly, symptoms, which is a very late manifestation of heart disease. And that can tell you about your risk in the coming months to years. Lastly, if your EKG shows you you're having a heart attack, well, that's telling you your risk now. I mean, it's happening now. So now that we have the crystal ball, how are we going to use it? Are we going to use it? Are we going to make good use of it, or are we going to, you know, similar to my analogy with the hurricane, where everyone saw it coming, but some people just didn't get out of the way? That this part is up to you and what you do with the information that your doctor can get for you. So just to summarize again, all the crystal balls, we have the risk factors that talk about, that translate to what's happening in your artery wall and your lifetime risk for heart attack. We have the imaging studies that can show coronary calcium. We have the stress testing, which can detect blockage of your coronary arteries. And then we have symptoms, and finally the EKG. So what do you do if you have risk factors? Well, you have to try to control them, at least the ones you can. You can't do anything about your age, family history, or gender, but you can do something about tobacco smoking, diabetes, hypertension, LDL cholesterol, and HDL cholesterol. These involve lifestyle changes or taking medications, watching your diet. The next thing you can do is, if your doctor feels it's appropriate, they can order for you a calcium score or CT angiogram and assess how much calcium you have in your coronary arteries. Well, you might ask, if I already have the process in my coronary arteries, what can I do? I mean, is there something I can do to change my risk at that point? Fortunately, there is. So there's different kinds of plaque. There's stable plaque and there's unstable plaque. If you imagine rocks, you can imagine two different scenarios where you have this rock formation here, which has probably been here for hundreds of years, if not millions, where this rock is just balancing. I don't know if you can all see my pointer, but this rock is balancing. Looks like it's about to fall over, but it's probably been about to fall over for hundreds of years now. This is analogous to a stable plaque. Whereas at the top, you see these rocks that have fallen down in an avalanche down the mountain and are now blocking the road. These were unstable rocks. And so what is the difference between a stable rock and an unstable rock? And in our analogy, is there a difference between a stable plaque and an unstable plaque? There is. So this is a graph that shows people who have a calcium score of 0 in orange. And in the dotted line orange, it's people who don't take statin, like Lipitor. And in the solid orange, it's people who do take statin. And you can see that their risk of having a cardiac event is pretty low, but not 0, increases over time. And there's no difference in whether you take a statin or not if you have no calcium or little calcium in your coronary artery. In the blue is shown people who have a high calcium score, and in the dotted line, dotted blue, are people who have a high calcium score who don't take a statin, and in the solid blue line is the people who have a high calcium score who do take a statin. And you can see that taking a statin, even when you have evidence of calcium and plaque, lowers your risk of cardiac events. So the statin does something to the plaque. It stabilizes the plaque. If we go back to our analogy with the stable rock and unstable rock, you can understand what I'm talking about. When you have plaque, you can stabilize it with a statin. Are there other ways to stabilize it? Yes. The other way to stabilize it is by taking a blood thinner like aspirin. Multiple trials have been done in people looking at heart attack, stroke, or any kind of vascular event, and the effect of aspirin on this. And globally, aspirin cuts the risk of heart attack, stroke, or serious vascular event by about 20%. And so thinning the blood has an effect on that plaque. It makes the plaque less likely to clot. And as we saw on the prior cartoon of the coronary artery, the clotting of the plaque is what causes heart attack. And so if your doctor tells you you have coronary calcium, he or she may suggest to you that you should be on an aspirin if you don't have any issues with aspirin, like allergies or stomach problems. So number one, you should be on an aspirin. Number two, you should be on a statin to stabilize that plaque and cut your risk of heart attack and heart disease. So if you have plaque, can you gain more information? Can you go a step further? Yes, you can. You can know if that plaque is impinging on the channel of your coronary artery. Is it blocking flow? And we do that by stress testing, which we discussed. So many of you remember, I don't know, 6 months ago when this tanker blocked up the Suez Canal and all the mayhem it caused. So let's draw an analogy. So let's say this tanker was not oriented in this angular way, but was straight. It would have gone straight through and not blocked any passage of any other boats. And so we can draw an analogy and say that this tanker is like plaque. If the plaque is parked against the wall of this canal, this channel, it's not going to block flow or cause problems. But if that plaque becomes eccentric and protrudes into the channel, then it's going to cause lots of problems. And even beyond that, the location of this blockage is important too. Look at where the Suez Canal is. It's, you know, it's a narrow bottleneck and everything has to go through there. So if you can imagine this tanker being stuck here in the Nile River, it wouldn't have been as bad because huge tankers don't have to go through there, but it's at a critical point that controls a large territory. And so where the plaque is important, drawing on this analogy. So as I told you on an earlier slide, the degree of ischemia you have translates to your risk. And so if that plaque is in the beginning part of a major artery, it controls a large area of your heart muscle and can put you at risk for a big heart attack or a lot of ischemic events. So what can you do if your doctor does a stress test and finds that you have ischemia? Well, one option is coronary angioplasty. You all know what coronary angioplasty is, I'm sure, where we take a balloon and go into the area where the blockage is. We inflate the balloon and then we put a stent in there to keep that blockage open. So I just want to make a few comments about coronary angioplasty. A lot of trials have been done with coronary angioplasty, comparing it to not doing any kind of invasive treatment and comparing it to just medications. And the bottom line is coronary angioplasty helps you by taking away your chest pain. It does not prevent a heart attack and it does not make you live longer unless it's done in the setting of an acute heart attack. So this trial was done 2007, quite a while ago. It's called the Courage trial, and they compared people who have coronary artery disease and angina by putting them on medications versus doing angioplasty. Now, the people who got the angioplasty had less chest pain, but they didn't live longer and they didn't have a lower risk of heart attack. This is kind of an important concept that a lot of people don't quite understand. It's not really intuitive. This other trial was another pretty big trial called the FAME trial. And in this trial, they went a step further than just looking at a blockage. They measured the blockage in the cath lab with something called a flow wire and determined how much ischemia it was causing. And so they divided people into 3 groups here. So in the yellow are people who had the angiogram, found with the flow wire that there is ischemia, there is lack of blood flow, but they treated them with medication, no angioplasty. In the blue are people who got the flow wire, were determined to have ischemia, significant blockage, and they were treated with angioplasty. And in the green were people who got the flow wire, were not determined to have ischemia, did not have flow reduced. They just had plaque, but not enough to reduce flow. So they also got treated medically. And so they followed these people over a year and found that the people who got just medications, who had a significant blockage, had higher events. Now, what were these events? These events were chest pain and future need for angioplasty. Whereas the people who had the significant blockage and who got angioplasty had a lower risk of future events, but it was about the same as the people who did not have a significant blockage, but did have some plaque and who got the medication. So this was angina events and the need for angioplasty. But if you look at people who died, they were all the same. Everyone who got medications, regardless of whether they got angioplasty or not, had the same death rate. And on the bottom left, panel C here, heart attack, they all had the same amount of heart attack too. So if you take medicine, regardless of whether you get an angioplasty or not, your risk of heart attack is approximately the same as someone who gets an angioplasty. Urgent revascularization, meaning you kept having chest pain, you had to come back and get an angioplasty. Well, the people who got treated just with medications from the get-go, they were the ones who kept having chest pain and needed to sometimes have an angioplasty. So the bottom line is that angioplasty reduces symptoms of angina, but angioplasty does not prevent a heart attack, and angioplasty does not make you live longer, which is an important point, which I think is not well publicized. So let's look at another sort of analogy here. If you say that plaque is like snow, there's two ways to treat snow. You can plow it and you can open up the road so that cars can pass. And that's great, but it doesn't prevent more snow from falling and re-blocking the road. But it helps you for a while. Or you can pour salt on the snow, which will melt the snow. And even if more snow falls, it will still continue to melt because the salt is still there. So in our analogy, let's say that a snowplow is like doing an angioplasty. It clears up the blockage, but it does not prevent you from having a heart attack. It does not prevent more plaque from depositing. Whereas the salt, pouring the salt on the snow and ice is kind of like taking a statin or taking an aspirin or doing other things that control your risk factors, like controlling your diabetes, hypertension, and not smoking. That is what ultimately affects your lifespan and risk for having a heart attack. So to draw it all to a conclusion here, be heart wise, know your risk factors, get your blood pressure checked, get your blood sugar checked, get your cholesterol checked, live a healthy lifestyle. Don't smoke, don't eat ice cream every day, don't eat fatty foods, fried foods, or at least keep them to a minimum. Do some tests and figure out if you have plaque. And if you have a lot of plaque, do things that stabilize it. And then if deemed appropriate by your doctor, look for ischemia. And if you have ischemia, treat it. And lastly, understand the symptoms of heart disease so that if you get these symptoms, you go and see your doctor. In summary, this is the bottom line: make smart choices and stay safe.